common arterial trunk. This, to me, is the one lesion that certainly does benefit from translation. Because if you use the term truncus arteriosus, it's not immediately understandable. Whereas if we say common arterial trunk, then the term speaks for itself. And this is the definition that we gave for the entity that we're going to discuss in one of the earliest papers I wrote. This, in fact, I didn't write the paper. The paper was written by my good friend Giancarlo Crupi, who was one of the first people to come to work with me when I started in the 1970s. And this was the definition we gave in our paper in 1976. I think it still holds good. As you see, a solitary trunk, a common valve, supplying directly the aortic, pulmonary, and coronary arterial pathways. So we exclude from common arterial trunk aortopulmonary window. That is because in aortopulmonary window we have separate aortic and pulmonary valves and separate outflow tracts. We exclude origin of one pulmonary artery from the aorta, even though some people call that hemitruncus. I think that is an horrendous term and should certainly not be used. And of course, we distinguish the common arterial trunk from a solitary arterial trunk, albeit recognizing the solitary arterial trunk may be trying to be a common arterial trunk. But nonetheless, the solitary trunk in clinical terms fits much better with tetralogy, with pulmonary atresia, with the common trunk. So this is what we are talking about, and I'm sure you will see several examples of this very shortly. The trunk supplies directly the brachiocephalic arteries, the pulmonary arteries, and the coronary artery. And as you see, it is leaving the base of the heart, the arterial valve. So let me emphasize again the distinction from solitary arterial trunk. And this depends upon the presence or absence of an intrapericardial pulmonary trunk. Because when there is no intrapericardial trunk, and that is absent when we have confluent pulmonary arteries and duct, but no pulmonary trunk, non-confluent pulmonary arteries with bilateral ducts, and the system with systemic to pulmonary collateral arteries, or the arrangement I showed you yesterday, where on one side there was a duct, on the other side systemic to pulmonary collateral arteries, but certainly no intrapericardial pulmonary trunk. In that circumstance, we cannot determine, had it been present, whether the atretic trunk would have arisen from the heart or from the solitary trunk. So returning to common trunk, perhaps most important are the associated malformations. And we can list these, and we will describe a ventricular septal defect just as we did in the isolated heart. The way that the trunk arises from the ventricular mass, the feature that in the past has most frequently been used in classification, I'll discuss that with you. But don't forget the arrangement of the aortic arch, that is also used in categorization of common trunk. And whilst in many instances there is no arterial duct in the presence of common trunk, you need to recognize the cases in which the arterial duct is present, because that can feed significant parts of either the systemic or the pulmonary pathways. And a feature of common arterial trunk is an abnormal pattern of the coronary arteries. And sadly, unlike the other conditions we've been discussing today, transposition, congenitally corrected transposition, double outlet right ventricle, we cannot use the concept of the facing sinuses because, of course, there is a solid arterial valve. So let's go through those with a degree of speed, starting with the ventricular septal defect. Now, if you study the literature, you will find that in some instances, cases are described in which the ventricular septum is said to be intact. And in the first description of that was because during ventricular diastole, the leaflets of the common truncal valve apposed not only with each other, but with the septal crest. So during diastole, it was argued there was no ventricular septal defect. But this does not hold good, of course, when the leaflet's open, because then the septal deficiency immediately becomes recognizable. So we would not call that an intact septum, although we recognize it's an important finding. But then cases certainly can exist in which the common arterial trunk arises exclusively from the right ventricle, if you like, double outlet through a common truncal valve, and then the ventricular septal truly can be intact. So it is possible to find examples of the common trunk truly with an intact septum. But in most instances, there is a juxta-arterial subtruncal defect. And as with all other defects, that can exist when there is continuity between the arterial valve and the atrioventricular valve, making it perimembranous. But most usually, there is a muscular postero-inferior rim. And then a key feature for the geneticists, and particularly for counseling of patients, is that the common arterial trunk is closely related to the doubly committed arterial ventricular septal defect, and I'll show you why. But let's first look at the features that make the ventricular septal defect either perimembranous or permit it to have a muscular postero-inferior rim. So here I'm showing you a picture of the origin of a common arterial trunk from the ventricular mass. And the key feature is the postero-inferior margin of the defect. So if we blow that up, you can then see that the ventricular infundibular fold stops short of the posterior limb of the septomarginal trabeculation. And in the area where the ventricular infundibular fold has stopped short, there is fibrous continuity, extensive fibrous continuity, between the leaflet of the tricuspid valve and the leaflet of the truncal valve. And of course, as you are now well aware, the atrioventricular conduction axis is penetrating through the posterior part of that region of fibrous continuity, so it is at danger during surgery. But we can unequivocally recognize these two phenotypes, and with mitral atresia, the ventricle is small or even a virtual slit, lacking fibrillostosis, whereas it is only in the presence of mitral stenosis that we see the hypertrophied ventricular walls and the marked fibroelastosis that is part and parcel of the phenotype in this particular variant of hyperplastic left heart syndrome. And it is only then, in these cases with mitral stenosis, that we see changes in the coronary arteries, which have been so beautifully shown by my other good friend and colleague, Willie O'Connor, who works with Jackie Noonan still now in Lexington, Kentucky, which is a delightful the conduction axis. And the surgeon is able to place his stitches along this muscle bar when using a patch so as to put the common arterial trunk back to the left ventricle. So from 2/3 to 4/5 of patients with common arterial trunk will have this arrangement with muscular postero-inferior rim, and only a minority will have the perimembranous defect. I show a place to visit, I must say. But you must note the similarity of this defect in common arterial trunk, in which we have a common ventriculo-arterial junction, with the arrangement seen in the doubly committed and juxta-arterial ventricular septal defect. Again, we have a common ventricular-arterial junction, but this time it is divided by a raphe into separate pulmonary and aortic valves. And we can make the analogy here with common atrioventricular junction, with common valve, and with the so-called ostium primum defect. So the doubly committed ventricular septal defect is, as it were, a common ventricular arterial junction, but with separate arterial valves for the right and left ventricles. And these two entities are very closely related genetically. When we contemplate the way the arterial trunk arises from the ventricular mass, you are all well aware that in most instances there is a balanced origin of the trunk, and it arises more or less half and half from each of the ventricles. There is then a spectrum of malformation, however, And in the extreme forms, the common trunk can rise exclusively from the right ventricle, oftentimes then with a muscular support separating the truncal valve from the mitral valve, or it can arise exclusively from the left ventricle. The feature in the past that most frequently was used for subcategorization of common trunk was the nature of the pulmonary arterial pathways. And this was the system introduced by Collett and Edwards, and they indicated that you could find instances where the right and left pulmonary arteries arose by a confluent segment from the common trunk, and they called that type 1. And we now know that there is a variation in this pattern in which the confluent pulmonary arterial segment arises within one of the truncal sinuses, albeit that that is very rare. Collett and Edwards then distinguished their second type, in which the right and left pulmonary arteries arose separately from the back of the common trunk, which they dubbed type 2. But unfortunately, in many instances, the arrangement is intermediate between so-called type 1 and type 2, so many describe type 1.5, which doesn't really help us very much. And a variation in the origin of the arteries from the back of the trunk is seen when the right pulmonary artery takes origin before the left, and then the pulmonary arteries cross as they extend to the pulmonary hilums. The rarest type is where the right and left arteries arise separately from the sides of the trunk, dubbed by Collett and Edwards type 3. And then, of course, you can have non-confluent pulmonary arteries, with one of them fed by an arterial duct. The so-called type 4, which was initially identified by Collett and Edwards, we now know is not a common trunk, because that is the type in which there is absence of the intrapericardial pulmonary trunk, and so now we would call that a solitary arterial trunk, and we would not group that along the fossa itself. But in a proportion of cases, probably 10% of autopsy series, the atrial septum is seen to be intact. The aortic arch is right-sided, and indeed it is tetralogy of Fallot and common arterial trunk that make up almost all the cases of those with congenital malformations having a right aortic arch. The significant point, however, is more in terms of interruption of the aortic pathways, and that interruption, as we will discuss very shortly, can occur between the left carotid artery and the left subclavian artery, or it can occur at the isthmus. It can also occur between the coronary arteries, although that is exceedingly rare. And then there can be aortic coarctation. And we must not forget the association, when we have interruption of the aortic arch, with the left subclavian artery. And of course, common arterial trunk, as I've just discussed, is common in the setting of 22q1111. Deletion, catch-22, is now a pejorative term, so not used. 22q11 deletion, much better. And in reality, these abnormalities of the aortic arch can also coexist with any arrangement of the pulmonary arteries. But this is the typical situation. You see that my probes have been introduced through the pulmonary arteries, which are arising separately from the back of the pulmonary trunk, so-called type 2. But there is interruption here between the left common carotid artery and the left subclavian artery. And here then is the duct descending aorta. And then, as I've stated, there is no distinctive pattern for the coronary arteries, but frequently they take their origin above the sinotubular junction, and the surgeon needs to be particularly aware of origin of the coronary arteries close to the origin of one of the pulmonary arteries, and particularly frequent and troublesome, a single coronary artery.